Dạ, xin phép các quý vị đại biểu, các thầy cô giáo cùng các quý đồng nghiệp, thời gian cho phiên buổi chiều đã đến. Xin phép các quý vị đại biểu, các thầy cô cùng ổn định vị trí để chúng ta bắt đầu phiên buổi chiều hôm nay ạ. Xin phép các thầy các cô ạ.
Okay, thank you. Ladies and gentlemen, we would like to start this afternoon, the first session in the afternoon. And first of all, we would like to invite Dr. Vũ Thị Huyền from Tâm Anh Hospital, Hanoi, to present a topic named lower urinary tract infections in spondyloarthritis patients, clinical and paraclinical characteristic and some related factor. Dr. Huyền.
Good afternoon, everyone. My name is Vũ Thị Huyền, and I am from Tâm Anh General Hospital, Hanoi. It's a great honor to be here today to share with you my presentation on lower urinary tract infection in patient with spondyloarthritis, clinical, paraclinical characteristics, and some related factors. The first part is problem statement. Spondyloarthritis (SPA) is a group of autoimmune disease that are seronegative with a rheumatoid factor. It is strongly linked to the SLA B27 characterized by chronic inflammation and joint fusion. In SPA patients, lower UTIs are common but often atypical or non-specific with the high rate of silent bacteriuria. If untreated, lower UTIs may lead to renal dysfunction, secondary sepsis, and make worsen SPA symptoms. This complicates the management of SPA. However, up to now, these issues have not received enough attention in clinical practice. Therefore, we conducted a study on lower urinary tract infection in patients with spondyloarthritis to evaluate the clinical, paraclinical characteristics and some related factors. Next is the overview part. Patients with SPA often suffer from chronic ulcer and peripheral joint pain, affecting daily life and quality of life. The long-term treatment often include NSAIDs, corticosteroids, DMAIDs, and biologics. The increased risk of lower UTIs in SPA patients may be attributed to systemic inflammation from the disease, prolonged immunosuppressive therapy, reduced mobility, and mechanical change in the urinary tract. And what are the common causes of lower UTIs in SPA patients? According to many previous reports, the most common agent causing lower UTIs is the Enterobacteria family, particularly gram-negative bacteria, led by E. coli. They are found in 70 to 90% of community-acquired UTIs, have a strong tendency to recur and increasingly resistant due to their ability to adhere to the urinary tract mucosa through ciliated structure called villi and fibri that can bind to receptor on urinary epithelial cells. And now we come to the subject and method section. This study was conducted at the Rheumatology Department, Tâm Anh General Hospital, Hanoi. Selection criteria: diagnosed with a diagnosis of a SPA according to ASAS criteria, concurrent lower UTIs confirmed by positive urine culture, and provided consent to participate in the study. Exclusion criteria: patients were excluded if they have severe comorbidities, other infections such as pneumonia, ear, nose, throat infection, gastrointestinal infection, soft tissue infection, and spondylodiscitis, and declined to participate in the study. And here I want to mention a valuable test for diagnosing lower UTIs, urine microscopy. This test analyzes a urine sample, often midstream or catheter urine, under a microscope to evaluate the physical, chemical, and microscopic characteristics of the urine. It helps to diagnose various conditions, including lower UTIs. This test is so simple, fast, and cost-effective for diagnosing lower UTIs, especially in cases before having urine culture test result. And now, regarding the study results and data connection, we perform a systemic assessment of each patient, including general characteristics, clinical feature of lower UTIs, present symptom of lower UTIs, particularly fever, dysuria, urinary frequency, coronary urine, hematuria, and lower back pain or suprapubic pain. Paraclinical characteristics, blood test to assess systemic inflammation, and urine test, complete urine analysis, leukocyturia, hematuria, and nitriuria. Urine microscopy, leukocyturia, hematuria, bacteriuria, and especially in urine culture, name ESBL production ability and antibiotic resistance status. And here are the results and some discussion. First is clinical characteristic of lower UTIs in SPA patients. As shown in the first chart, 68.29% of patients had symptomatic lower UTIs, while 31.71% of cases had asymptomatic bacteriuria, confirming that many SBA patients may have silent lower UTIs detected only by urine test. Among symptomatic cases, dysuria was the most common symptom, followed by lower back pain and urinary frequency. Other less frequent symptoms included cloudy urine, hematuria, and low-grade fever. So, dysuria, low back pain, and urinary frequency were the key symptoms of lower UTIs in SPA patients. And about urine test result, we perform both complete urine analysis and urine microscopy for comparison, revealing notable differences. In most patients of lower UTIs, complete urine analysis detected infection through hematuria, pyuria, and nitrite. However, urine microscopy show higher sensitivity in detecting hematuria and leukocyturia. If only looking at the leukocyturia and nitrite in complete urine analysis, many cases of lower UTIs may be missed. Notably, 89.219% of cases had a positive urine culture, have visible bacteria under microscope, confirming its role of this test in early detecting lower UTI in SPA patients. And about bacterial counts in urine microscopy, this test showed that most patients had low bacterial count, with the majority below 500 bacteria per microliter. In cases where count exceeded this threshold, lower UTIs were often typical with clear symptoms, making diagnosis in this situation is often straightforward. But low count cases with a typical symptom pose a challenge. Turning to the bacterial cause lower UTIs, our finding align with local and local chains. E. coli was the most common agent, accounting for 70.72%. Other notable agents include Staphylococcus species, Streptococcus species. Next common bacteria included Klebsiella pneumonia, Pseudomonas aeruginosa, Proteus mirabilis, and Morganina morgani. The prevalence of ESBL producing E. coli. A key finding in our study was 31.7% of E. coli isolate was ESBL positive, making up nearly one-third of cases. This extended spectrum beta-lactamase ESBL producing bacteria produce enzymes that can break down many common antibiotics, including penicillin, most cephalosporin, first to third generation. As a result, this antibiotic become ineffective for treating infection caused by these resistant strains. And here antibiotic resistant status of E. coli. On a positive note, E. coli isolate showed high sensitivity to key antibiotics such as carbapenem, amikacin, fosmicin, and nitrofurantoin. However, cephalosporin susceptibility was more moderate. Ceftazidime 65.38%, ceftriaxone 70.83%. Regarding resistance rates, ampicillin 82.75% resistant and 3-methylprimethylsulfametazone 68.97% resistant. And especially about fluoroquinolone group, the resistance was high with 56.67% to ciprofloxacin and 42.86% to levofloxacin. This is alarming because fluoroquinolone is one of the mainstay for treating lower complicated lower UTIs. And at the end is my conclusion. 31.7% of SBA patients has a symptomatic lower UTIs, highlighting a significant silent burden. Urine microscopy is crucial for early UTI detection in SBA patients and should be routine performed in clinical practice. E. coli was the most common causative agent, and nearly one-third of cases were ESBL positive with high antibiotic resistance, leading to increased treatment costs and a greater healthcare burden. And this concludes my presentation. I sincerely thank all of you for your attention. I hope my presentation can provide the insight into lower UTIs in SBA patients, contributing to a more comprehensive and effective approach to their treatment. Once again, thank you very much.
Thank you for a very good presentation. And is there any question from audiences? We need to put 1 or 2 questions for grading. So if you do not have any question, Dr. Cho, do you have any? Oh, yeah, I have one. Okay, in general, you have about 31.7% of the patients in your group have infection in the urine tract. Do you have any percentage of the female and male in the study specifically?
I have the general characteristics of the subject.
You just answer a short question. The percentage of the infection
In our study, the
urinary
rate
tract.
of male was about more than 60% patients.
In male?
Yes.
Male or female? Male, right?
Male.
So male is higher, much higher than.
Yes.
Okay, that's very, very noticeable, very important. Because
Yes, SBA patient, the male is more than female. Because the selection
I know, but 66?
more than 60.
60,
Six.
right?
Yes.
That's very high. Because normally in urinary tract infection is common in women, not in men. And these
Yes.
are young patients, so it's very important. That's what I'm thinking. Yeah. Okay. Anyway, thank you. All right. Any questions? All right. No questions. Then we'll move to the next speaker, Dr. Nguyễn Thị Kim Hương from Nguyễn Tri Phương Hospital, from Ho Chi Minh City, right? Dr. Hương will give a talk on the prevalence of osteoporosis, low TBS, and fracture risks in patients with rheumatoid arthritis. Dr. Hương.
Dear respected professors and colleagues, today I'm honored to present a summary of my studies under the guidance of Associate Professor Nguyễn Đình Khoa. And the title of my study is The Prevalence of Osteoporosis, Low Trabecular Bone Score, and Fracture Risk in Patients with Rheumatoid Arthritis. Here is the content of my talks. As we all know, osteoporosis is a disease characterized by low bone mass and structural deteriorations of bone tissue, leading to bone fragilities and increase the risk of fracture. And based on BMDs only, osteoporosis is defined as a BMD score of less or equal to minus 2.5. However, more than 50% of osteoporotic fracture occurs in patients who do not belong to the osteoporosis category. I'm sorry, I repeat once again. Osteoporosis is the disease characterized by low bone mass and structural deterioration of bone tissue, leading to bone fragility and increased risk of fracture. And based on BMD only, osteoporosis is defined as BMD score less than equal to minus 2.5. However, more than 50% of osteoporotic fractures occurs in patients who do not belong to these categories, and that's the reason why the tools like trabecular bone score and fracture model are crucial for better understanding the fracture risk in patients. And the new techniques, the new trabecular bone score, it is not a direct measure, but a texture analysis related to bone microarchitecture. It is computed data contained in the AB spine DEXA scan, and as we can see in the first above image, is the image of a normal person with well-structured trabecular bone score, and here we have the TBS, which is high, and comparing to the lower image with the osteoporotic patients, the TBS is lower. And TBS is now largely used in a lot of clinical research, and more than 1,000 peer-reviewed publications, and is recommended in over 30 national and international guidelines. And we all know the FRAC score. This is the country-specific fracture risk assessment tool for many countries in the Asia Pacific. And the APCO is an organization of the regions who propose that the intervention threshold can be considered, including the history of fracture, the BMD score of the values less than 2.5, and a high fracture risk. And this organization also supports the use of the FRAC score to the risk fracture assessment. And we know some data about rheumatoid arthritis and osteoporosis too. Bone damage is one of the most significant extra-articular manifestations of rheumatoid arthritis, driven by chronic inflammation leading to increased bone loss. And we have the prevalence of osteoporosis in some studies, which show here, and one study of the prevalence of low TBS, and now also, we consider there's a high fracture risk in RA patients. Most of them occur above the osteoporotic threshold, and TBS has been shown to be lower in RA, and is an excellent predictor of vertebral fracture, especially osteopenic patients having RA or on those on glucocorticoids. And to address this, my study focused on the three key objectives that aim to improve fracture risk prediction and indication for treatment in RA patients. Those are the three objectives. One, determine the rate of osteoporosis and low TBS. Objective 2, assessment of 10-year fracture risk by FRAX and TBS adjusted FRAX. And objective 3 is to determine the proportion of patients with the indication for osteoporosis treatment according to the guideline in our RA patients. And this is the cross-sectional studies with patients diagnosed of RA by the ACR 2010 criteria, aged between 40 and 90 years. And we exclude the other autoimmune disease, metabolic disease, mental illness, pregnancy, BMI out of the range of 15 to 37, and the history of spine or to hip surgery. And this is the sample convenience continuing sampling. We have data from December 2023 to June 2024, and our sampling size is calculated to be 97, and we actually recruited 131 patients. And those are our data collection with anthropometric measurements, with lifestyle, previous structure, medical history, medication, and factor related to RA like disease duration, the DAS28, structural damage, functional impairment, and sarcopenia as defined by the SAC-F. And we also have the laboratory test within the 3 months. And our study, we also measure BMD S2 size by our machine. And with that measurement, we define the osteoporosis criteria according to WHO. And then we calculate the TBS based on the DEXA scan. And those are the analysis from our collaborative team in Switzerland, Medimap group. And we also categorize the TBS into cutoff by 1.32 and 1.23 to be normal, to be partially degraded, and degraded or what we call degraded is low TBS. And then we calculate the flux and the flux TBS using the web tool, but we use the Thailand version because we don't have the Vietnamese version. And then we also categorize the flux MOF and flux HF to be normal, to be medium risk and high risk. And this is a flow chart of our study. The data analysis, we're using SPSS 20 to analyze. And this is the result of our studies. Out of the 131 participants, 83.2% are female, and the female-to-male ratio is 5:1. And the mean of our age group is 60, with the standard deviation 9.3, and this is comparable to other studies in the world. And for BMI, in our studies we have the mean of our BMI is 23 with a standard deviation of 3.4, and this is a little bit lower than the studies of Tavasoli, but higher than the study of Trần Thị Hằng. And the distribution of the BMI show in the charts and compare with male and female, as we can see here. And for the body composition distribution, we have 51, more than a half of our population have normal BMI, but then mostly another half is overweight or obesity, and we have very few patients with underweight. And consider the comorbidity and fracture history. This horizontal chart, we have some comorbidities that we see here, and the most prevalent comorbidities are hypertension, which counts 44.3%, sarcopenia 20.6%, and diabetes 17.5%. And this is comparable to other studies in the world. We have also 21% of patients with a personal fracture history, and 9.2% with a family history of fracture. The characteristics of a factor related to RA in our study, we have the disease durations. We have RA disease durations of a median of 7 years, and with an interquartile range from 3 to 11 years. The disease activity score by DAS, VS, and CRP are shown as 3.4, 2.6, and 41% of our study population have structural damage, and 11.5% of our study population have functional loss. And we also have some details about inflammation marker and the percentage of high positive RF and high positive anti-CCP is also very high in our study too. And osteoporosis and RA treatment. In our study, we have a lot of people, patients with glucocorticoid treatments, 61.1%. However, they only use mostly two-thirds, only use low dose of steroid, less than 5 milligrams per day. And for the treatment by disease-modifying drugs, most of our study population use DMARDs or monotherapy. We have a few who use biologic DMARDs or the DMARD target synthetics or the combination. And for the treatment of osteoporosis, more than two-thirds of our patients have calcium supplements, and about one-third of our population have vitamin D supplements. And the treatment by bisphosphonate, comparison of bisphosphonate treatments from our other studies, we have the same percentage of using bisphosphonate at the study of him in Korean. And this chart shows the bone density classification and TBS classification. In our study, we have 22.1% of patients with osteoporosis by the total whole classification, and 55% which is osteopenic. And for TBS, we have 26% low TBS and 35% with the partially degraded TBS. And when we combine TBS and osteoporosis, we have 32.8% of patients with high risk, and this make it an increase of 10.7% if we comparing to the osteoporosis alone. And our study have the prevalence of osteoporosis, which is in between some reported of the RA population in Germany, Mexico, and Morocco. However, it's a little bit lower than the Korean studies or another study by our college, Đào Hồng Hạnh, which includes only women postmenopausal or women more than 50 years of age in early RA. And our low TBS prevalence are 26%, which is a little bit lower internationally, and the discrepancy may be related to the characteristic of the population, to the technical use of the BMD machine, or to the reference rates. And we also study the concordance between classification of TBS and BMD. We find a low concordance with Kappa equal to 0.2, and this is compatible with the Manitoba cohort in the general population. So we advise to use the combination of both TBS and BMD to study about bone health. And between FRAX and TBS adjusted FRAX, we also analyze those are the concordance between the TBS and between the TBS adjusted FRAX and FRAX MOS, and we also have the comparisons of different categories, high risk, medium risk, and low risk, and we found the concordance of Kappa is very high too. So we advise that TBS adjustment does not significantly increase the FRAX risk estimate for MOF and HF, and we can use simple FRAX only. We don't need to do the TBS adjusted FRAX in this case. But we remarked for RA patients here, the FRAX is very high for FRAX HF at 50.4%. And the proportion of patients with high fracture risk according to AFCO, for the criteria of AFCO to give a threshold for treatment, if the patient previously have a fracture, the first criteria, we have 21.4% of our patients have fracture history, and this is higher than the general population by another study of both in Ho Chi Minh City. We also have a lot of patients with osteoporosis, but we remark even higher osteopenic patients with high FRAX HF risk. So we think that reliance solely on BMD for diagnosis may overlook patients with a high FRAX HF risk. that is also considered high risk for fracture too. And also the combination make our studies, we have more than half of patients who have indication for treatments, and even in the group of untreated patients in the middle, the color yellow, we have 47% of patients who need treatment. So conclusion, osteoporosis in our study is 22%, low TBS 26% combined. We can identify 32.8% high-risk cases, and we need the combination of TBS and BMD for bone health assessment. And FRAX and FRAX adjusted is very high concordance together, so we don't need to use TBS adjusted FRAX. And we use FRAX, we can detect a lot of patients high risk for HF FRAX. And the third objective in our RA patients, more than a half needs osteoporosis treatments, and even the patients untreated, we still have mostly a half meet the threshold for osteoporosis treatment too. The limitation of our study, this is a cross-sectional design study lacking of the control group of non-RA patients. We have insufficient evaluation of lifestyle and nutrition factor in osteoporosis too, and some limitation about the diagnostic tool. And we recommend the combination of BMD and TBS for bone health assessment in RA, and using modern tools should be selected appropriately based on specific clinical scenario too. Thank you for your listening. I'm sorry, this is an old version, but when there's technical problem, they make it an old version without any words, so I have to set on myself.
Okay, thank you, Dr. Kim Huang. You give us a very interesting presentation. Very sorry, it's a very long time. Yeah. I have some question for Dr. Huang. First of all, I want to ask you about you in your presentation. You have you have talked about the damage of joint. So what kind of technique you use to determine the damage of joint? For example, sharp score or MRI, or you should definite in the in. Yeah. So you use a sharp score? Yeah. And how to use assessment the TBS by DICSA?
Okay, thank you. Anyway, it's very good presentation, and your English is very good, to me at least. It's hard to imagine. You say that you send the results to the Switzerland for your colleagues to analyze that for you by the normal DEXA results, or?
It's not the result of the DEXA, but it's the DEXA scan. It's from the machine, our holographic machine. We do
You do that with the normal DEXA machine, like hologic, or you use the X-ray machine?
No, not X-ray.
Normal X-ray machine.
Normal. Our hospital has hologic. We have to use the modulation of the platform so that it is compatible with the TBS analysis, and then we sort out the scan image from the spine, lumbar spine. They are the same image of the DEXA.
Okay. So that's the software only. You use the same data from the Excel machine and then you send to your colleagues. They have software to analyze that. Okay, anyway, I have one question for you because in your study, you said that the TBS does not affect the results of the track assessment, right? And okay.
And TBS adjusted frac, which means that the frac calculator we put on the data of TBS, there's another option for TBS adjusted frac below the frac website.
Okay, it's a bit complicated, so make it short. If TBS does not help much for your fracture risk assessment, do we need to do this procedure to our patients? Because to me, it seems that your TBS does not help very much. And even with the patient with normal TBS, you still have a number of patients with osteoporosis and fibrosis. So I think it's good. It's good study, and we need more work to clarify the role of the TBS. They start to talk about that. They start to talk about the TBS in the diagnosis of osteoporosis, but in official recommendation at the moment for diagnosis and treatment, TBS has not been implemented.
Yes.
So this good study, but still a lot of things we have to do.
Because in my studies, I found that the TBS is independently give the fracture risk through the BMD. So the association between the two had the fracture risk prediction increased 10.7%. But it's just we don't need to do the TBS adjusted fracs. And FRAX is a different tool. FRAX is also a tool to evaluate the fracture risk for the patient because even though osteoporotic patients have increased risk of fracture, but we have mostly 50% of the osteoporotic fracture, but only with osteopenic status. So we need to have other tools to increase the fracture prediction.
I understand, but with the normal BMD or osteopenia, you still have tools to diagnose the osteoporosis, and you can have the academic treatment. What I mean is that this is not very useful at the moment, and maybe the patient needs to pay some more money for this. And I'm sure that you may have to spend more time to do this procedure for each patient, right?
No.
No?
Usually it's the programmation. If we can attach it to our machine, then we can do it all at the same time because it uses the same image. We can do the next step with the TBS, but because we don't attach the software inside our machine, so we cannot do it the TBS. Yeah. Thank you very much.
So the next presentation will be the Phạm Chính Nghĩa, Dr. Phạm Chính Nghĩa, with the presentation. Tên là gì ạ? Intermittent fasting reduce crystal induced inflammation.
Thank you. Dear Professor Nguyễn Hùng, dear Professor Trần Tô Châu, good afternoon everyone. My name is Phiên from Department of Internal Medicine of Hải Phòng University of Medicine and Pharmacy. And so today I'm so glad to be here to speak to you about our study on the intermittent fasting, which reduces crystal induced inflammation that I have performed during my thesis in Biological Research Unit in Paris, France, where I defense in December 2024. So for beginning, in rheumatology, there are two main types of microcrystalline disease. The first one is the gout due to deposition of monosodium urate crystals called MSU crystals, As you can see here on the left, observed under polarized microscopy, you can see the MSU crystal are needle shape. And the second one is due to the deposit of calcium pyrophosphate diarrhea crystals. And you can see on the right, the CPB crystal rectangle different from the MSU crystal. In fact, the two main type crystals are responsible sometimes in acute recurrent inflammation. So this inflammatory response depends on the production of interleukin-1 beta or I1 beta through ARP3 activation pathway, including two signals concerning the immune cells such as macrophages or neutrophils. As you can see here, for signal 1 of primary signal leads to the production of pro-I1 beta in nucleus of the cells. And the secondary signal, due to the stimulation by crystals on the membrane of cells, that could trigger the maturation of pro-I1 beta to I1 beta to release the cytokine outside the cell. So there are many environmental factors such as the diet, the caloric restriction, or intermittent fasting. We could modulate this inflammatory response. So according to a pilot study on very few number of patients, of gouty patients, showing that after 4 months of dietary intervention by the caloric restriction, the number of gout attacks per month was reduced. But the authors didn't investigate the underlying mechanism of this modulation. However, the hypothesis probably proposed is that during the caloric restriction or intermittent fasting, the organism induces fatty acid oxidation to produce energy necessary for its functioning, and the end products of this fatty acid oxidation process, they are ketone bodies, beta-hydroxybutyrate or acetoacetate, which could be also anti-inflammatory metabolized through activation of autophagy. Besides that, we have many strategies of dietary intervention. So you can see here, for example, the caloric restriction, time-restricted feeding, intermittent fasting, and in our study focus on the alternative fasting, meaning 1 day fasting followed by 1 day feeding alternatively. The question proposed, does intermittent fasting reduce crystal-induced inflammation? How does it do that? And is there a new metabolite which could mimic the anti-inflammatory effects of the fasting? So to answer these questions, we use the mouse model, as you can see here, by creating the air cavity, by injecting the air under the skin of mice to create joint cavity patients. So we divided all the mice to 2 groups, normal diet groups and intermittent fasting group, with 2 non-consecutive day fasting during week before the stimulation by crystal, by injecting the crystal into the pouch to mimic the gout flare. And we are waiting for 6 hours to simulate the pouch and to collect the samples to assess. For example, we collected the washing liquid by washing the air pouch. The air pouch membrane is like synovial membrane, serum also, to assess firstly the inflammatory level, and secondly to perform metabolomics analysis. So for results, you can see that the intermittent fasting reduces microcrystalline disease, inflammation, assessed in air pouch washing liquid. You can see that in the liquid, at the level of the cell number infiltration, in the red group, the cell number was drastically reduced after the fasting compared to normal diet group in black. And similarly, we measure also several pro-inflammatory cytokines such as the I1 beta, CXL1. And for example, here you can see that I1 beta concentration was also reduced compared to normal diet groups, especially in the groups stimulated by the crystal of MSU or CBBD. And then we assess also the inflammatory level by histology, by HNE staining. So the score is quantitative, semi-quantitative score ranging from 0 to 4. You can see here, 0 is like no information, until 4 is the most important information. So for results, yes, you can see in membrane on the right is fasting groups, and on the left is normal diet group. Stimulated by PBS, MSU, CPP. Normally, for example, you can see in normal diet, groups stimulated by MSU, you can see the level. It should be about 3. But after fasting, you can see that in this group stimulated by crystal of MSU, the level is 0. And this inflammatory score was also quantified, so you can see clearly the significant difference. So the intermittent fasting reduces crystal-induced inflammation. So to better understand the mechanism of this modulation, we perform also secondary the metabolomic analysis by the method of liquid chromatography analyzed by metabolomic platform. So for results, you can see, for example, here we have pathway enrichment analysis assessed in the upper membrane of the mice, compare between the fasting versus normal diet group. So you can see here we have many metabolism pathway were enriched. For example, amino acid pathway, fatty acid pathway, carbohydrate pathway. Especially, we found arginine proline metabolism pathway were enriched not only in the membrane but also in the serum. So, what is this proline arginine metabolism? By literature, as you can see here, this pathway of proline arginine metabolism, it can be metabolized to transfer to the polyamine metabolism, and this polyamine metabolism includes several polyamines such as the putrescine, spermidine, and spermine. Interestingly, in the serum, you can see that the spermidine concentration was increased after fasting compared to normal diet group, whatever the stimulation, suggesting that the spermidine could be potentially an anti-inflammatory metabolite. So intermittent fasting reduces crystal-induced inflammation by changing many metabolism pathways, including producing more spermidine. So another question proposed, does the supplementation of spermidine could mimic the anti-inflammatory effect of fasting? So from that, we try another in vivo experiment on the same airpulse mouse model. 3 weeks before the stimulation by crystal, by injecting crystal in airpulse, 2 weeks before the stimulation, we supplement the spermidine in the water of mice, and we strengthen also 1 dose of spermidine in the airpulse by injection. And after 6 hours stimulation, we collect all samples to assess inflammatory level. And you can see here similar results with the intermittent fasting when reducing inflammatory level in the washing liquid. For example, cell infiltration at the level of pro-inflammatory cytokine I1 beta 6 cell1 concentration. So, intermittent fasting reduces crystal-induced inflammation by producing the spermidine, and in contrary, spermidine supplementation can also mimic the anti-inflammatory effect of fasting. So, the aim of the next study would be to increase the spermidine concentration in the body. So by literature, you can see that we have three main ways to increase the spermidine concentration by the cellular metabolism, by intestinal production, through microbiota metabolism, and the oral uptake, food uptake, which is the most interest here. So we can find many sources of food which are rich in spermidine. For example, wheat germ, fermented soybean, cheese, mushroom, peas, nuts, etc. And then we are looking for also whether there are the clinical trial of spermidine supplementation on gout disease. So we found 3 studies in recruitment patients and 7 studies finished. And among them, we find many diseases they apply the spermidine supplementation. For example, they assess on-cause mortality. When supplementing spermidine, it could reduce the mortality or improve also immunity function by inducing autophagy, for example. But we never find the clinical trial of the supplementation of spermidine in the research field of microcystic disease. So it would be interesting to try to supplement in human. So intermittent fasting reduces or induces inflammation by changing many metabolism pathways. In vivo, we had tried to supplement the spermidine in the ear pouch mouse model and found that the spermidine seems to mimic anti-inflammatory effect of fasting. And in future, the supplementation of spermidine it would be interesting to treat gout flare patients. So I would thank first Vietnamese Association of Rheumatology for accepting our abstract to present today. And I would like to thank my colleagues from my research unit BioSCAR in Paris, to my 2 supervisors of ITS, Professor Thomas Baran and Professor Ancoria. And then I would like to thank Haiphong University of Medicine and Pharmacy, where I'm working. And finally, I would like to thank French Embassy in Vietnam, who gave me the scholarship to perform my thesis. Thank you for your attention.
Okay, thank you, Dr. Nghĩa, for very good and interesting abstract on your study. Is there anyone who wants to ask question to Dr. Nghĩa? Okay, Dr. Big.
Yeah. CPP?
I think he didn't do that.
Because CPP? Yeah. MSc crystal. Because in rheumatology, the gout due to the deposit of uric crystal and the CPP crystal, there are two main types of this microcystic disease. What? Polarized light. No, can I explain you again about our experiment? on mouse. This one. This one. Next. Yeah. So you can see we have three groups that we first we had created an air pouch. It's like air cavity to mimic joint cavity patients by injecting the air on the skin of
So you inject these chemicals into the
yes, we
mouse skin.
So in this air pouch, we injected the synthetic crystal in the air pouch.
I know.
Yeah.
So
Sterile crystal.
you created
Yeah,
you created the
I created-
pouch.
Yeah, a pouch.
yourself.
It's like a joint cavity.
Okay, you
Yeah.
just inject some air into the
Yeah,
under skin.
under skin.
Understand? He created a pouch under the skin and inject things into it. This is the model. This is the
Yeah,
model.
it's
It's
like model.
mimic the joint cavity, not the real joint cavity.
Yeah.
So and he not detect any PPD or anything. He inject them into the pouch. Is that right?
Yeah.
Okay.
Yeah.
So
Just
why
I
do you need to
inject.
why do you
Yeah.
need to clarify what you know for sure, Dr. Beat? Okay. Anyway, I think this is very good good study, but this is the indirect evidence. You just speculate from what you do into the disease in human,
Yeah.
right? So I think it's a good idea, but the persuasive evidence is not very strong. And another thing is that because based on your results from your study, you think that if people can do some fasting intermittent or some interval meals, that can help to reduce the inflammation caused by gout. And you cannot do that with human. So you instead you force them to skip some meals. You supplement what's
Yes,
thing
the
the
spermine,
spermine
yeah.
into the diet.
Yeah.
And then you hope that with that stuff can help the patient to reduce the inflammation caused by the diseases,
Yeah.
caused by the
Yeah.
crystal.
Yeah.
Okay. Anyway, that's good idea, but that's for research. But in clinical application or in the treatment application, I think it's still very long
Yeah. It's
way to go.
It's a huge challenge.
And you do this you do this abroad, not in Vietnam.
Yeah. During
Paris.
my thesis. Yeah. During my thesis.
In Paris, where
in
you are
Paris, yeah.
studying or you have been staying there, right?
Yeah.
Okay. Anyway, it's good. It's provide us some option, some way, some pavement to go for further study in the future.
Yeah.
And if Dr. Big wants to do something with him, you do the same thing. Instead of giving the mice with some chemicals into the skin, you
Yeah.
do give humans something into via mouth, via oral way. Oral, this
Yeah.
means through mouth, not mouth. So I think you have the same idea with Dr. Big, and if
Yeah.
I think you can combine,
She,
work together and
yeah.
make something very, interesting and marvelous.
I know she's working on the microbiota, and
Yes.
the next thesis after my in Paris,
Okay.
they work on the microbiota concerning
Another
intermittent
project
fasting. Yeah, intermittent
Paris?
fasting. Yeah, another project. Yeah.
I know. It's very
Yeah.
common things now, and because in Vietnam we do not have, Professor Tâm. Oh, okay, Dr. Tâm. That's in Vietnam we do not have enough facility and
Yeah.
condition to do some study like microbiota or something like that, or even with study like this. But in the near future, I think we can do that, and
Yeah.
it's important. But the gap, the distance between the study from the bench to the bedside is a long way to go. But
Yeah.
anyway, we have to do something like this, so we can make the gap between the laboratory condition and in clinical setting come
Yeah,
closer. It's good. Thank you.
thank you.
Okay. So the next speaker will be Dr. Phạm Thị Hằng from Huế University of Medicine and Pharmacy. Will give us another presentation in eosinophilic granulomatosis with polyangiitis, EGPA, a case report.
Yeah, thank you. Dear Professor, dear audience, my name is Thang. I'm a third year resident of University of Medicine and Pharmacy, Huế University. Today, I'm glad to be here to present an interesting topic, eosinophilic granulomatosis with polyangiitis through a case report. A 17 Vietnamese girl student was admitted to the rheumatology department caused fever, eruptive cough, and rashes of the trunk and extremity. Doesn't have on face. Her complex medical history began at 3 months old with bilateral deafness following otitis media and mutism at 1 year old. She has a history of asthma, purpura, GI bleeding, and hematuria episodes. From March to July 2024, she was diagnosed and treated for SLE, asthma, and heart failure. The chart above summarizes the patient's medication history. We can see that she has had episodes of using various immunosuppression, such as cyclophosphamide, mycophenolate, mofetil, SCQ, corticosteroids, and even plasma exchange. On clinical examination, we observed the following symptoms with fever, productive cough, mild to state dyspnea, decreased lung ventilation, scattered crackle in the lower lung area on both sides, wheezing on both lung floor, digestive symptoms with diarrhea. Digestive symptom with diarrhea and vomiting, and purpura throughout the body. As observed, upon admission, the patient exhibited a number of palpable purpura on the palm and shoulder, which is subsequently disseminated to the abdomen, upper arm, and lower leg. And 10 days later, correlating with the timeline of 3 days following an escalated corticosteroid regimen, the lesion has markedly regressed and was almost entirely resolved. This symptom remind us to think about the small vasculitis associated with ankle. And regarding the blood test, the complete blood count revealed persistent eosinophilia with eosinophil count consistently exceeding 20%, showing a trend of decrease following 2 days of increased corticosteroid doses. This accompanied by anemia, and the hemoglobin level also demonstrates a trend of improvement, correlating with the reduction of the eosinophil count. And blood biochemistry recorded an infection starting from day 6 with elevated, the blood biochemistry recorded an infection with elevated procalcitonin level that gradually decreased by the July 11. CRP decreased from 62 grams per liter to 13 grams per liter, and the patient's serum IgE level was 2297 and subsequently decreased to 1355-52 after 10 days. Autoimmune markers such as ANA, dsDNA, and the antiphospholipid antibody of B or C anchor was all negative. There was slight increase in proteinuria, but it did not exceed the nephrotic range. Parasitic test was negative, and a kidney biopsy was performed in the patient's history, but no abnormalities related to the condition was observed. And echocardiography found that heart failure with reduced the ejection fraction with an ejection fraction of 49%. Left atrium dilator, left ventricle thickened and dilator. Chest X-ray show the interstitial thickening of both lung field, mainly in the right lung field, and SRCT following pneumonia, bilateral lung infiltrate. Chest SRCT following pneumonia, bilateral infiltrates, bilateral interlobular septal thickening, bilateral pleural effusion, and pericardial effusion, and the skin biopsy, we don't see the deposition of the eosinophil. Endoscopic ENT, we have found that the exacerbation of chronic rhinosinusitis and left nasal polyps. And this table summarizes the involvement of the organ in our patient with system disorder, dermatology, pulmonary, gastrointestinal, cardiology, and ENT system. And because the patient is mute and deaf, it was not possible to perform the electromyogram test successfully. This is also a challenge in this diagnosis. And based on the patient's medical history, clinical presentation, and result of ancillary laboratory tests, the patient was diagnosed with ECB according to 2022 ACR and Euler criteria, which I will present later. And with the infected bronchial asthma and heart failure. So this is some review of eosinophilic granulomatosis with polyangiitis, which gripped by ECBA. ECBA was first reported by Charles and Stroll in 1951 and classified as a type of small vasculitis associated with anti-anchor, which is characterized histologically by eosinophilic tissue infiltration in addition to vasculitis. And the annual incidency and prevalency of this disease is 0.9 to 2.4 per 1 million people and 10.7 to 17.8 per 1 million people respectively. It mostly affected subjects between 40 to 60 years old, and the mean age is diagnosis is 48 years. ECBA pathogenesis is not well known. It has been proven that HLA-DRB1, 4, and 7 and HLA-DRB4 and 2 haplotypes of IL-10 promoter genes are the most studied genetic determinants. Among acquired pathogenic factors, the exposure to the different allergens, infection, vaccination, drugs, and silica exposure has been involved. And a link between B and T inflammatory responses may explain the different symptoms in the exacerbations. This table summarizes the ancillary, the clinical manifestation among the previous study. As you can see, we can observe that female are more and male are the equivalent rates, and the leukocyte count as well as acetylcholine level are elevated in most studies, particularly showing in a significant increase in studies conducted in Japan. The positive anchor rate is approximately 30 to 47%, and in this study, the pattern of organ involvement varies across different studies. However, neurological, ENT, skin, and pulmonary involvement predominate in all studies. Ocular involvement is rarely observed. ECBA is no test can confirm the ECBA. And in 1990, ACR published classification criteria ECBA to identify the condition, includes 6 criteria. presence of 4 or more of these 6 criteria was associated with a sensitivity of 85% and a specificity of 99.7%. However, it has not been recognized, and beyond this, 2022 ACI and EULA has introduced the innovative ECBA classification standard, and the classification criteria include 2 parts of clinical criteria and laboratory and biopsy criteria. A score of more than or equal 6 is needed for classification of ECBA. And example with our patient, she has 11 points with obstructive airway disease, nasal polyp, and serum eosinophil counts more than 1 multi 10 to the power 9. The treatment is based on the 2021 ACI and EULA guideline. First is some definition term in the guideline. Example with our patient, she has symptoms of vasculitis with cell line or organ-threatening manifestation with rhinosinusitis, asthma, mild systemic symptoms, uncomplicated cutaneous disease. And so we can define her have non-severe active disease. We can return the key recommendation for the treatment of eosinophilic granulomatosis with polyangiitis. Our patient have 3 options in order of reference. One is the glucocorticoids plus mepolizumab, and 2 is the glucocorticoid plus methotrexate or glucocorticoid with azathioprine, or glucocorticoid with mecophenolate mofetil, and final is the glucocorticoids with rituximab. About our patient, we choose the option 2 for patient, and after stabilization of infection, she was continued with treatment using intravenous corticosteroids at a dose of 1 milligram per kilogram per day for 3 days, followed by a transition to oral corticoids in 4 weeks and with a gradual dose reduction, maintaining a dose of 20 milligram per day, and this was combined with methotrexate. This was combined with methotrexate with 15 milligram per day, alongside symptomatic treatment for asthma and management of heart failure, and has demonstrated a marked improvement in clinical symptoms after 3 months of treatment, a boost of pupillary immersion. However, the symptoms improved spontaneously within 2 days despite no change in the treatment regimen, and the patient has seen maintenance remission to the present. And the result is as same as with the previous study outcome. Generally, the response to glucocorticoids in ECBA is good, and the 5 and 10-year survival rates were higher. However, patients with ECBA frequently relapse during glucocorticoid tapering. And in conclusion, ECBA was classified as a type of a small vasculitis associated with the anti-anchor, which is characterized histologically by eosinophilic tissue infiltration in addition to vasculitis. The exact cause of ECBA is unknown, but it is classified as an autoimmune disorder. It is believed that several different factors, including genetics and environment, play a role in the development of the ECBA. Most patients have multi-system, and almost patients have asthma, and no have diagnostic criteria just have a classification criteria of ACI and EULA 2022. Treatment was according to guide in the ACR and EULA of management ECBA 2021. And despite the great level of knowledge reached, more has to be done to clarify EZBA pathogenesis, and genome-wide association study will be probably help to better understand the genetic determinant of the disease. Besides, the environment factor also must be studied in depth in the future, defining diagnostic criteria, exploring biomarkers that can assist with the differential diagnosis and the assessment of disease activity are also the most important. Finally, the indication for new treatment options need to be better defined. And this is all of my topic. Thank you for your attention.
Okay, thank you, Dr. Hang from Huế University for the presentation. Because we do not have much time left, so we need to speed up. We don't have any question for you, but we have short comment. Do you think that this is infection associated with the necrotizing vasculitis? This is one of the considerations. Okay, you think about that later, not now. But I think it's one of the options, one of the possibilities that you need to consider, because the patient have procalcitonin very high all the way, and your skin biopsy doesn't show any immunology evidence for that. So should be careful. I know I can ask you later, but now we don't have time any more time, so we will stop here. Please come back to your seat. Thank you. The next speaker will be Dr. Nguyễn Thị Kim Thanh from Chợ Rẫy Hospital with a presentation topic in interstitial lung diseases in idiopathic inflammatory myopathy. 2 case reports from a new and reviewed literature. Dr. Thanh.
Okay. Hello everyone. My name is Kim Thanh. I'm come from Chợ Rẫy Hospital. Today I'm here to present to you about a review of literature and 2 case reports of interstitial lung disease in idiopathic inflammatory myopathy. Here's the objective of my presentation. Interstitial lung disease is the common complication in idiopathic inflammatory myopathy with a prevalence of 42%, especially in anti-synthetase syndrome. The prevalence rate ranging from 70 to 100%. ILD is a poor prognostic factor for idiopathic inflammatory myopathy. The 5-year survival in progressive dermatomyositis associated ILD is 54%. The survival rate of polymyositis associated ILD is better. 5 years, about 70%. 10 years, 60%. For clinically amyopathic dermatomyositis associated ILD, rapidly progressive ILD has a 6-month survival rate of 40%. Classification of myositis based on EULAR and ACR 2017. There are 7 main types: dermatomyositis, clinically amyopathic dermatomyositis, polymyositis, overlap syndrome, anti-synthetase syndrome. The last two classifications I'm not going to mention because ILD is rare in this syndrome. Now let's discuss the role of autoantibody in myositis. We have a group of myositis-specific antibodies which are essential for early diagnosis, classification, treatment response. First is ARS autoantibody, including anti-Jo1, anti-PL-12, which is associated anti-synthetase syndrome and high-grade ILD. And second is anti-MGA5, is strongly associated amyopathic dermatomyositis. This autoantibody is particularly important because it is highly related to rapidly progressive ILD. And now we have another group of autoantibodies which are myositis-associated antibodies, including anti-PMACL, anti-KU, SSI, SSB. Is associated to overlap syndrome. Depend on what side of autoantibody is overlapped to systemic sclerosis, SLE, or Sjögren's syndrome. And now, diagnosis of ILD. Imaging is play important role in the diagnosis. Chest X-ray show reticular finding, nodular mixed pattern, no relationship between chest imaging and disease stage. Honeycombing is poor prognostic factor. There is 10% of normal chest imaging in ILD. SRCT without contrast is golden standard to diagnose ILD, staging, and monitor treatment response. The prognostic factor for poor outcome, acute onset type of amyopathic dermatomyositis, present MTA5, radiographic findings show rare glass opacity, lower consolidation, normal CK, high ferritin, and the factors for good outcome, chronic onset type of polymyositis, present ARS antibody, rare glass opacity, reticular opacity, honeycombing, consolidation alone in radiographic findings, high CK, normal ferritin. And now we move on the guidelines for treatment of ILD in patients with myositis. The first line ILD therapy includes mycophenolate, azathioprine, rituximab, and short-term glucocorticosteroid. If the patient fails to the first line ILD therapy, nintedanib should be considered. And as you can see on the slide, it's in the trial show the role of nintedanib in the treatment of the patient with pulmonary progressive fibrosis. Nintedanib can slow the rate of FVC decline in ILD patients with pulmonary fibrosis. Progressive fibrosis, especially in patients of connective tissue disease-related ILD. And here's the Vietnamese guideline of ILD 2023. It divides ILD manifestation into rapidly progressive, acute, and chronic. With chronic condition and MDA5 positive or anti-ARS antibody positive, corticosteroid and immunosuppressants for the treatment. And now I'm done the review of literature, and now we move on case report. And case number 1, a case of 45-year-old female patient with a past medical history of post-procedural hypothyroidism at the age of 18 years with good compliance. In June 2024, she had front pain. 4 months later, she had muscle weakness in the extremities, mild dry throat, dry eyes, and dry mouth. 1 month later, she had progressive muscle weakness, fatigue, shortness of breath, difficulty swallowing, and fever. She came to VRA hospital. Her physical exam is generally normal, excepting mild tachycardia and fever, and the most significant finding is proximal muscle weakness and chest clear in pulmonary exam. The laboratory testing showed mild anemia, elevated inflammatory marker, high liver enzyme, high CK with of approximately 2,000 unit liter, elevated LDH. EMG showed concerning for inflammatory myopathy. Serology panel show ANA positive, anti-Jo1, anti-SSI positive with very high titer and high MGA5, high positive row 52 positive. The slide emphasizes the important CT scan over chest X-ray. Chest X-ray is normal. CT scan show reticular finding on basal lung, including subdural and low FVC of 56%. With all clinical symptoms and laboratory tests, she was diagnosed of polymyositis overlap with Sjögren's syndrome associated with ILD and post-procedural hypothyroidism. We prescribed her methylprednisolone 40 mg per day and isotopin 50 mg per day. She had a good prognostic factor because of present NTA5 and ILD. She also has a good prognostic factor for chronic presentation, type of polymyositis, ARS antibody. The outcome, she has a good response to the treatment, even though there were poor prognostic factor in addition to good prognostic factor. So poor prognostic factor is not always indicate poor outcome. And now we move on, case number 2. A case 39-year-old male in 2022. He had peripheral joint pain, erythematous papule occur symmetrically over his dorsal hand, especially involving finger joints and elbow. He also has skin rash over his chest, no muscle weakness. In May 2024, he has worsening joint pain, fatigue during exercise, dry cough. He came to Hahao Medical Center where were conducted chest X-ray with result of bilateral basal lung damage. Specialists there suspected him pulmonary tuberculosis and transferred him to Phongmothap Hospital. During 4 months in Phongmothap Hospital, he was conducted in extensive investigation for ILD related to autoimmune disease and transferred to VRA Hospital. His physical exam is so impressed with generally normal, excepting diffuse erythematous rash on his face, involving nose and cheek. He has a V5 and periungual erythema rash and gastron papule positive. Laboratory testing impressed with normal CK and LDH. EMG show suggesting of muscular disease. Serology show NA indeterminate and MBA5 positive. The chest X-ray show reticular on basal lung, and chest scan show reticular finding and honeycombing on basal lung, indicating fibrotic interstitial lung disease. Normal FEC, normal bronchoscopy. He was diagnosed of amyopathic dermatomyositis with MDA5 positive associated ILD. We prescribed him methylprednisolone 40 mg per day and mycophenolate 2 g per day. He has poor prognostic factor because of type of amyopathic dermatomyositis, MDA5, and he also had ILD. The outcome, she has a good response to the treatment because we have the early combination corticosteroid and immunosuppression for the treatment. Okay, now I have some conclusion for my presentation. ILD is a common manifestation in patients with idiopathic inflammatory myopathy. Autoantibody testing is very essential for classification, prognosis, and treatment. With clinical simple skin lesion, we should not for diagnosis of amyopathic dermatomyositis. ILD is usually associated with few clinical symptoms. It's necessary to perform SRCT for ILD diagnosis. ILD is poor prognostic factor when associated with idiopathic inflammatory myopathy. Thank you for listening.
Okay, thank you. Thank you, Dr. Tang, for your very good presentation. Do you know that you are a very special speaker today? Do you know? Oh, this is, look, all the audiences. Very important persons are here. You see, Dr. Professor Khoa, Dr. Ling, and all other hospitals are here. So you're very special. Congratulations. Anyway, we don't have any more time, so we would like to invite the last speaker to the podium to present rectus related femoris ultrasound functions in sarcopenia screening for the primary knee osteoarthritis patients? Dr. Min.
So good afternoon. I'm the final presentation in this section. So hopefully you will enjoy my presentation. It's my pleasure to stand here and present our study at the conference. My title is The Roles of Rectus Femoris Muscle Ultrasound for Sarcopenia Screenings in Patients with Primary Knee Osteoarthritis. Here in my content include 4 parts. OA, osteoarthritis, by its turn, is the most common articular disorders riding at the population age and affecting up to a fifth people worldwide, third being the most prevalent cause of joint disease globally, and the knee was the most popular site for osteoarthritis. Sarcopenia is a degenerative and generalized skeletal muscle disease in which there is a decline of skeletal muscles combined with low muscle strength and low performance. Sarcopenia is known to be associated with negative outcomes like fractures, disability, and increased mortality. Sarcopenia and knee OA are 2 major risk factors for fall in older adults. The coexistence of these 2 conditions may exacerbate the risk of fall. Participants with sarcopenia and knee OA have 4 times higher odds of recurrent fall than healthy controls. In the past, underlying mechanism of sarcopenia has mainly focused on malnutrition, obesity, or vitamin D deficiency. Recently, the local and systemic inflammation has been reported as leading to the sarcopenia. And as we know that the local inflammation is the most mechanisms of osteoarthritis. The European Working Group on Sarcopenia in Older People and the Asian Working Group for Sarcopenia recommend that the diagnosis of sarcopenia should be based on the combination of muscle mass, muscle strength, and physical performance. Muscle mass has been measured by several techniques like CT or MRI. But CT and MRI is very expensive and not routines in clinical practice. So ultrasound is another technique that can be used to assess the sarcopenia, and you see on the figures that the comparison between US score and histological score is the same. So the updated version of European Working Group on Sarcopenia in older people recommends that ultrasound as a valid and reliable tool for measuring muscle mass, and but further study required to assess its potential because the sensitivity and specificity are variables. The representative muscle had not been determined. The cutoff point of ultrasound parameters for diagnosing sarcopenia had not been established. And in Vietnam, no study about the roles of muscle ultrasound for sarcopenia screening in patients with knee OA. So we conduct this study aimed to The second one is that's why the ultrasound measurements of the rectus femoris muscle in knee OA patient with and without sarcopenia. And the second one is to determine the cutoff of parameters on rectus femoris muscle ultrasound for sarcopenia screening. About the methods, study participants, we include the patient with primary knee OA, Smith ACR 1991 criteria, and we include the participant with any objectively detected muscle weakness or secondary sarcopenia. The defined sarcopenia according to Asian Working Group on sarcopenia 2019 criteria. The rectus femoris ultrasound we assess bilaterally on the long axis and short axis view. We collect the standard examination parameters include penetration angles, muscle thickness, cross-sectional areas, as you see on the figures. And about the results, our study includes 95% in week, 87 female and 8 females. The descriptive clinical data for each group are summarized in the tables, and we see that no difference between in sex, height, weight, body mass index between the sarcopenics or non-sarcopenic group. The mean age of the sarcopenic group were higher than non-group. In radiologic assessment, the sarcopenia group have more patients in severe states than non-group. And as shown on the figures, the prevalence of sarcopenia in patients with knee OAs were 72%. As the diagnosis of sarcopenia differs from the character, our data shows that relatively high than other studies. And about the ultrasound measurements of the rectus femoris muscle, average of rectus muscle thickness, cross-sectional areas, and the facial length, and finally the penetration angles in the sarcopenic patient were significantly lower than the control group. And our study reveals that the most common ultrasound parameter for diagnosing sarcopenia was the muscle thickness, cross-sectional area, facial length, and penetration angles with the good AUC values. And the cutoff point, 15 millimeters were established as the threshold to assess the presence of sarcopenia by ultrasound. And as you see in the figures, the rock analysis of muscle thickness, the sensitivity of the ultrasound was, we have a good sensitivity and specificity. The rock analysis was performed in order to qualify how accurately rectus femoris muscle thickness can discriminate between the sarcopenic and or non-sarcopenic state. And we have a good AOC value was 95%. But muscle thickness and cross-sectional areas presents the muscle quality. Additionally, some studies report that echo intensities and other ultrasound parameters reflect muscle qualities. In context of muscle ultrasound, the muscle quality refers to the relative presence of different component muscle tissue like muscle, vascular, or fibrous, or fat tissue. So in our study, we doesn't collect the echo intensity. So the muscle qualities have recently been considered as the important muscle quantities for defined sarcopenia. And here our conclusion: the ultrasound parameters of rectus femoris muscle in knee OA patients with sarcopenia include muscle thickness, cross-sectional areas, facial length, and penetration angles were lower than the control group. The rectus femoris muscle was strongly related to sarcopenia in knee OA patients, and the cutoff values for screening sarcopenia were revealed. Thank you for your attention.
Okay, thank you, Dr. Min, for the very good presentation. Because the time is up, so we don't have any more discussion session after this. So thank you, everyone, for coming and present very, very good topics and research studies today. And we finish this session here. Thank you for everyone.